Good evening, guys, and thanks for joining us today for our hosted by orthopedic specialists. As you know, we do these webinars approximately once a month, and the experts from the group, from orthopedic specialists, come and present the kind of work that we're doing within the group with different specialties coming to give us a talk once a month. Today, it gives me great pleasure to have Mr. Nima Heidari and Mr. Tom Crompton come and go through and share their ideas and management of complex limb deformities. And they're going to go through this in a stepwise fashion, covering all the different age groups, and hopefully give us an idea of the kind of patients that they can help look after and help you to manage your patients. Orthopedic specialists is a group of 20 or so orthopedic surgeons, pain specialists, spinal specialists, and more recently, these are handpicked guards that have come together to form this team of surgeons. The reason why we've chosen to work as a group is that we want to have the best possible available and manage all the different complex orthopedic and rheumatological disorders that we can help you out with. And we've even got a pain specialist on the team. We work out of Harley Street Specialist Hospital. This is based on Queen Anne Street, where we do all our outpatient work, and we've got theatres there to be able to do our day case operating. We're very grateful to the London Clinic, who kindly help support these webinars, and we do our major cases in the London Clinic also. And Mr. Crompton will talk about his work that he does out of the Portland Hospital, which is down the road from us. So the things that we're hoping to cover this evening include complex deformities, deformity analysis, strategy for correction, normal growth and development, and the growth problems arising from trauma. We're going to have Mr. Nima Heidari, who is a good friend and colleague of mine. He's a leading deformity specialist at Europe's largest trauma centre at the Royal London. He's also on the faculty for the advancement of trauma management with AO. He's heavily published in trauma management, and his subspecialist interest also is in foot and ankle surgery. And he's the go-to man certainly for people around London and UK. Tom is also a good friend and colleague. We trained together, in fact, and he's now a consultant at the Royal Alexandra Children's Hospital. He's an expert in all aspects of paediatric orthopedic surgery with a focus in children's trauma and deformity. He's also got an interest in cerebral palsy and neuromuscular conditions. When he's not busy looking after children and managing trauma, he's also a reserve officer in the evacuation squadron for the Royal Air Force. So I'm going to hand over to the guys now. Just a few house points. If you've got any questions, put them in the question and answer, and we will try and answer them as we go along, or certainly answer them at the end of each topic. Please fill out the CPD forms, which will follow soon after the talk. And once you do that, we'll be able to award you 2 CPD points for this evening. If you want to keep an eye on all the activity that we're doing within the group, please follow us on LinkedIn for orthopedic specialists. And we're also on Twitter, and these are our Twitter handles. We frequently have people coming to visit us at the hospital, whether to see the procedures that are going on, or just simply come and talk to us about. So feel free to get in touch via email or just simply call us, and we'll be delighted to help. So without further ado, I'm going to hand over to the guys. Nima, you're up first.
Brilliant. I think what we'll do, Tom, if did you want to start off, because I think your talk is much more about children's, and then it leads nicely onto mine when they get to adults.
That might be easier, yeah. So I'll do that if that's okay. So I'm just going to share my screen, and then start the talk. Hopefully you can see that okay, and welcome to this evening's webinar. Thanks for the introduction, Greg. So my name's Tom Crompton, consultant children's orthopaedic surgeon, and mostly work now at the Portland Hospital privately, and also a clinic at Spire Gatwick Park. So the whole webinar was entitled Complex Deformity, but I feel like, being a children's orthopaedic surgeon, I need to go into a little bit of the normal growth and development, so we can just understand what happens when it goes wrong and what we can do when it goes wrong as well. And then there's a little bit on traumatic growth disturbance. Obviously, in growing bone, if you get some trauma around the growth plate, that can lead to some deformities, and how I go about correcting those. If none of that works, then a friend and colleague like Nima will sort them out when they're an adult. But so the first half of this webinar is just going to be talking about children. So quite a few of the referrals to my practice will just be standard stuff with bow legs and knock knees, or rotational problems in children at varying ages, sort of in-toeing or out-toeing. And having a little bit of knowledge about what's normal can help you decide when you want to refer on to me, or when you want to refer on to anyone. Now, usually this is I usually do these talks in person, and it's a little bit more easy to be interactive. But when I show pictures of various children at different ages and try and get a handle on when people in the room would feel it's sort of abnormal and when it would warrant a referral. So again, a lot of the kids were referred for bow legs. If this is a 12-month-old kid being held up by mum in the photo, is that normal to have that sort of bow leg deformity? And if they're 18 months, is that normal? And when does it become something that we really need to refer and look into? And then a little bit later on in life, 3-4 years old, there's a lot of kids wandering around with knock knees. And again, when does that become abnormal? I'll try and give you an idea of doing that. So the children are all born bow-legged. Round about the age of 2, they become straight, and then we get a little bit knock-kneed before getting our sort of adult alignment, crone alignment, about the age of 10. Back in the day when you were allowed to x-ray hundreds of children, or at least examine hundreds of children, someone did a lovely graph for us so we can decide what's normal. Now the red line is the average. So you can see that all children are born bow-legged, and only really, there's a point on the graph around here, when they're around about 2 years old, if we take the green shaded area of the graph, which is 2 standard deviations, that's when we really should be worried about these kids who are bow-legged. If they're still bow-legged at that age, they certainly won't referral. Before that, if it's symmetrical and pain-free, it's usually, as long as it's within those 2 standard deviations, it's not something we need to be concerned about. And then you can see a bit further down on the, a bit further along on the graph, the maximum knock knee is about 3-4 years of age. So essentially the ones I'm, obviously if anyone's concerned about anyone, I'd happily see them, but the ones we're concerned about are any asymmetry, any pain, and outside those 2 standard deviations on the graph. And obviously if there's a leg length discrepancy, that's slightly different. So I'd fully expect a referral for any of this sort of asymmetry. And also this is sort of a slightly older kid, sort of 8 years old, to give you an example of when things aren't going perfectly well. It doesn't really matter what the underlying condition is for this, but it was treated and it was hypophosphatemic rickets. But you couldn't leave someone of this age with that much deformity. Now, luckily, I've got growth on my side as a children's orthopedic surgeon. So as long as the growth plates are still making some effort to grow, we can use some guided growth plates in these sort of children with deformity that's troubling for us. They're little plates which attach to the side of whichever bone you're trying to guide. In this case, the distal femur. You attach them across the growth plate, which is a very simple day case procedure. takes about 10 minutes for each plate we put in. And that works as a tether to the growth plates on whichever the side of the bone you're trying to slow down. We can keep them in for 2 and a little bit longer years sometimes to guide growth. Much longer than that, and we can risk sort of permanent growth arrest. But if you look at the kid here, put a couple of growth plates in, you can see obviously this is a number of months down the line. The left leg is already corrected. The right leg was obviously more severe, and it takes a bit longer to correct. And then these plates are great because you can see on that right-hand picture, we've taken one screw out to stop it working for a while, because this kid's very young and it's probable that it will rebound and you'll get more of a deformity again. And I can just put a simple screw back in at a later date in an even simpler procedure to correct the deformity again. So these things have really revolutionized practice in children's orthopedics over the last sort of 15, 20 years, really, because otherwise it was all big bony osteotomy procedures. Rotational deformity, so that's sort of looking at kids in the coronal plane, so looking at them from the front and deciding whether they're knock-kneed or bow legs. The other big number of children that get referred to me are those who are either in-toeing or out-toeing. In-toeing is obviously much more common. I don't think I have time to show you the video here, which is just of an assessment of a rotational profile, but I've got pictures that sort of that do the same thing. So trying to decide where someone's deformity is arising, because parents usually look at their kids in toeing and assume it's their feet or ankles that the problem is arising from, whereas far more likely and far more common it's actually a problem up towards the hips. But how do you go about deciding that? I don't expect you to paint the soles of all the kids' feet you see in your clinics, but you can just have an idea if you get them to walk up and down in the clinic which direction their feet are pointing. You don't need to know a degree, but is it significantly in or out? And then make sure you look at the foot. Just look at the lateral border of the foot and make sure it's straight, and try and draw a line in your head sort of up the heel, and it should intersect at the sort of second, third toe roughly. They're going to be wiggling their feet around, but if it's sort of way to the outside of the foot and they've got a curved lateral border, then that is a child I'd want to see and assess. But in most cases that's not the case. You've got a foot like it looks on the left there. Then you get the child prone, so get them on their front on the examination couch and just have a look. And again, this is a bit with the eye of the beholder, but you just line the foot up in its natural position and make sure it lines up with the thigh. It's pretty rare to have tibial rotational deformities, but it does happen. So you should check this after checking the foot to give yourself an idea that it's above that. And then you just rotate. This is, it's not amazingly accurate, but it gives you a very good idea about the rotations in the hip. And you should have roughly equal internal rotation, which is the picture on the left, and then external rotation of the hips, which is the picture on the right. So that's all pretty normal. What happens when I'm not saying this picture is not normal, but what happens when it's not normal? We get some children who have a lot of internal rotation at the hips and very little external rotation. The younger kids tend to sort of sit for long periods of time in this position, in this sort of W position. And it comes from the fact that we're born with our hips being very anteverted. And this is a graph, they're sort of pointing forwards quite a lot at birth, essentially. And then that over the first 10 years of life, that gradually improves. So if you're seeing young kids with in-toeing in your clinic, age sort of 2, 3, 4, parents can really be reassured that it's very likely to correct. You've got to choose your words carefully. You can't say they'll all correct, because they don't all correct, but it's very likely to correct. And if they don't, then obviously send them on to be assessed. Slightly more complicated rotational deformities. So those are the younger kids with in-toeing. If you see teenagers, they often have a lot of knee pain. And if you sort of line them up in front of you and it looks like their patellas are pointing at each other, just to try and make it easy for yourself to see what's going on. If you get the patellas pointing forwards, it becomes a bit more obvious then that they've got sort of external rotation of the tibia as well. And if you assess this on the couch, you would see a bit of external tibial torsion, with the feet pointing out to the side, and a lot of an excessive internal femoral sort of femoral anteversion as well. So they've got a sort of internal rotation at the femur and an external rotation at the tibia, and that can cause a lot of abnormal pressures on the knee and the kneecap particularly, which can lead to a lot of pain, hence the term miserable malalignment, which I try not to use in front of parents, but the kids are usually, or the teenagers are usually pretty miserable because it's often taken a long time to get to a diagnosis and any treatment if that's what's needed. For the kids who are very symptomatic, we can do a rotational profile on a CT scan. They just do limited images through the hips, the knees, and the ankles. And you know, if you've got very anteverted hips and you've got a very symptomatic patient, sort of activity limiting intervention, you know, after long discussions with the parents, it might be worth doing a rotational osteotomy, because you know, I'm not suggesting the vast majority of these children with rotational deformities get surgery. The vast majority of them do not need surgery. They need good physio and you know, a lot of encouragement to do that physio. But the ones who are resistant to that and really struggle with physio, it may be that rotational realignment of their lower limbs is what's needed. And that's a very easy operation for us because it's something we do for trauma all the time. But it is big surgery for the children. So moving on from the sort of coronal and rotational deformities, those are the normal growth problems I see. The other big part of my practice is deformity due to growth plate injuries. And I'll just go through a little bit of that. We try and avoid the damage to the growth plate in the first place, although sometimes it's done just with the trauma. So we try and fix them quickly. We try and we're careful when we reduce the fractures, and there's certain kits we use that to try and prevent further injury. Now, if you have an injury to a growth plate, either it won't, either none of this will happen, and that's hopefully the majority of the cases, or you can get a sort of partial growth arrest, which will lead to the bone growing off in a funny direction, so an angular deformity, a complete growth arrest, which is actually sometimes easier to treat, although it sounds worse, or you can get some loss of blood supply to a particular area of bone. All those things are problematic. We can classify them, but that's not that interesting. You've got to consider, or I have to consider, the cause of that growth arrest. Carefully judge using x-rays sometimes how much growth the children have remaining. The exact location and extent of the growth arrest with imaging, so CT or MRI, to decide where the growth arrest is, and then consider what surgery we can offer, whether that's corrective osteotomy or guided growth surgery, or left off there actually is now bone lengthening, which we do a fair bit of for the kids with significant leg length discrepancies. So what can we do? We can cut the growth arrest out, the sort of bony bridge that's formed across the growth plate. I can stop the growth plate growing anymore if I feel it's going to cause even more problems. We can do cuts in the bone and realign them, or we can do limb lengthening. So just one example of that, just to show, this is a distal femur fracture in a young child. Now, you know, it's a third or a half of these will go on to have some sort of growth problem just because of the anatomy of the physis here. It's very difficult to fracture right the way through your femoral physis without causing significant injury to the growth plate. So I probably treat sort of 3 or 4 of these youngsters a year, unfortunately, with significant growth arrest. Now, due to the age that they usually have these injuries, you know, more than a third of them will end up having a significant leg length discrepancy of 2 centimeters or more. This is not the same child, but this is another child who's had a distal femoral growth arrest, and they've got a central growth arrest. So if we're going to be able to excise it, you want to try and completely excise it and preserve as much of that physeal tissue as you can, and then stick something in the way to prevent that bony bridge recurring. This surgery it's tricky, and the outcomes, it's fair to say, are a variable. You can judge, hopefully, to the best of our ability, which cases are the right ones to try this on. and we usually get it right, but it is it's tricky, and you can't always predict which growth plates are going to carry on growing and which aren't. So there's various techniques to excise those physeal bars. If all that goes wrong, which it sometimes does, and you're left with a short limb, thankfully these days we're not using frames anymore, certainly in the femur, to lengthen bone without a deformity present as well. If you're just doing a straight lengthening, and I've had to do 3 of these in the last sort of 2 years, I think, for that exact case with a distal femoral fracture, ended on with a complete growth arrest. And the children who've gone through this in their sort of later teenage years, by the time we decide to do it, once their growth is finished, have managed this treatment very well. And this is bone lengthening is not what it used to be now for children. It's very well tolerated. So that's my quick whistle-stop tour through children's growth and deformity and a few traumatic injuries. I think we're going to, if you've got any questions to ask or answer, I can answer them now, or we can do some at the end.
Absolutely. There, just to let our participants and attendees know that there is a Q&A section in the webinar that you can use, and you can send us the questions and we can answer them as we go along. Tom, that's great. Thank you very much. I think the key thing is that if you're worried about deformity in a child, it's best to refer them, because there are nuances to assessing them and nuances to knowing when to intervene. So thanks for sharing those.
No worries.
I think what I'll do now is I will start my talk. Okay. Right, so I'm going to talk to you about the deformities, particularly as one grows. These deformities can become quite complex, and how to analyze them, how to think about them, and what to do about them, what techniques are available to us to try and help some of these individuals out. So these are my disclosures. I'm part of the orthopedic specialist group, and I operate at the London Clinic, the Harley Street Specialist Hospital, and the BMI London Independent in Stepney Green. The question really about deformity is, does it matter? Does it matter that a limb is deformed? And I think about this as, are we trying to deal with current pain and functional loss, or are we trying to mitigate future pain and functional loss? Here is an example. 55-year-old female. She fractured her femur in her teens, and she was treated with traction, which was the standard of care in the 1970s. You can clearly see that she has got a bent femur on the right side, and the way and you can see that quite clearly there. Here is another patient, bilateral tibial fractures, and you can see that the tibia on the right side is deformed. But to think about how important these deformities are, we do have some evidence. So this is a paper. It was a population-based cohort study. They looked at 1,500 individuals, and they looked at them with alignment films to assess, to look at the deformity in their legs, and also they measured their body mass index. The general finding is that if you have got varus or valgus malalignment and your BMI is greater than 30 kilograms per meter squared, you are likely to develop arthritis. So basically, deformity and obesity is a bad combination, particularly for knees. There are limitations to these studies. The information is scant about previous surgery and previous injuries, and it's not clear whether the malalignment is a cause or effect in this knee arthritis. But it is important to recognize that there are no studies who suggest that deformity is a good thing. And we have to bear that in mind. The lack of evidence does not mean evidence to the contrary. So I think that when you come across deformities, it's important to assess them and have a bespoke idea of what you want to do for these patients, depending on their problems. I'm going to talk to you a little bit about standard assessments for limb alignment, and also to say that the normal values can help with analysis. I know that some of you may not find this particular area useful, but it is important to understand the process that we go through to be able to analyze a deformity. The standard way to do it is to look at a hip, knee, ankle x-ray with the kneecaps facing forward. It's very important that they are centered on the femoral condyles so that the alignment is standard. And here it is. You can see, and Tom showed a lovely picture of this. Look, you've got the feet facing forward in this guy here, and the patellae are winking together because he's got external tibial torsion. You can see with the patellae facing forward, it looks very different, and you can have many degrees of deformity created or actually not appropriately analyzed by not having appropriate rotation here. So when you look at the x-ray, you find the center of the femoral head, you find the center of the ankle, and then you draw a line between them, the plumb line. It tends to go through the center of the knee, although a little bit to the medial side in the vast majority of cases. The other way to think about it is that we need to understand the alignment of the joint itself, and we do that by drawing a line over the distal femur. That is called the mechanical lateral distal femoral angle. That's usually about 87 degrees, and its opposing angle in the proximal medial tibia is also 87 degrees, and that gives us some idea of what normality would look like in the vast majority of individuals, although this can be different. Now, looking at the abnormal side, you can see that this plumb line is falling a long way to the medial side of this patient's knee, and she has got varus alignment. And in fact, the reason she came to see me is because she has got knee pain and she's too young to have a knee replacement. And one of my arthroplasty colleagues thought that we should think about doing something about the deformity, because certainly this way, by putting an arthroplasty into this knee, we are likely to have it fail early. Here it is. You can see the deformity. This is a simple deformity, uniapical deformity, and you can generally fix these with a single osteotomy and intramedullary nail, restoring the mechanical alignment of the limb. And here it is. It's gone on to heal at about 3 or 4 months down the line. The other thing to do is that just generally, what are these parameters that I'm talking about? On the left-hand side of the screen, we have got the mechanical axis, which is the plumb line that goes from the center of the hip joint to the center of the ankle joint. And on the right-hand side is the mechanical axis, which is the axis through the center of the bones. And the numbers here that are important are the lateral distal femoral angle, which I showed you, which is 88 degrees, 87 degrees, the proximal medial tibial angle, and also the lateral distal angle of the ankle. So these all match each other as we go down the leg. And the numbers, the concepts are exactly the same. The numbers are just a little bit different, and you can see that the mechanical axis is about 81 degrees. For me, normality is between 81 and 83 degrees, with similar angles for the tibia. When we think about any deformity, we can use 4 terms. There are 4 components to any deformity, and we can use them to analyze and describe that. And they include angulation, rotation, translation, lengthening, and shortening. The growth problems that Tom just explained to us about, they fall into the angulation, rotation, lengthening, shortening category. They're less common in translation in children, as they do tend to have correction of that alignment, correction of translation as they continue to grow. So here is an example. We have a 35-year-old male that had a traumatic injury as a teenager. Just by looking at him, you can see that there is an abnormality in the left side. We start by drawing the plumb lines, and we can see that on the left side where he has the problem, the plumb line falls a long way on the medial side. It's almost outside the knee. But looking at the normal side, we can see that he's one of these people who has got a normal varus alignment in his leg. His main problem is medial sided knee pain and back pain. we can now look at the angles, and we can see that lateral distal femoral angle is 102 degrees for him. Whereas we look at the contralateral side, it's the standard 87 degrees. We think about this deformity, we can resolve it to one plane deformity. But when we consider how I want to fix this, and we know that in the femur, external fixators are not very well tolerated, if we want to fix this with an intramedullary nail, we have to think about this deformity in a different way and think about it as a multi-apical deformity. You can see that there is a deformity in the mid shaft, and then further on down, there is a translational as well as an angular deformity. So in order to be able to correct this deformity, he requires two osteotomies, a two-level osteotomy and a retrograde femoral nail for us to be able to correct his alignment. And here he is from the pre-operative picture on the right-hand side and the post-operative picture on the left-hand side, seeing that his alignment is corrected. You can see that I've actually corrected his alignment on the affected side to the center of his knee because he had medial sided knee pain, and the MRI scan showed that he has early degenerative changes on the medial side. So for him to have a neutral alignment, I hope will give him some longevity to his own knee. Now, this is a post-traumatic deformity that has occurred in someone who had most likely finished growth. The next chap is a 30-year-old man, and he remembers falling out of a tree when he was a child and had a lot of pain in his right knee. He has, you can see the long leg alignment film, you can see that his right leg is short and it is deformed. In fact, the degree of deformity means that they couldn't actually physically get him onto one cassette to be able to image both sides at the same time, and we're missing a part of the lateral aspect of his right knee. The other thing to note is that this chap is really tall. It's 190 centimeters. And you can see that here we are, we can't get it. So I had to get extra radiographs, a single one-sided long leg film to be able to do proper deformity analysis for him. So let's think about what is going on with this guy. So the first thing is that he's got a 52 millimeter shortening in the femur of the affected leg, and a 30 millimeter shortening in his tibia. So both the bones are actually affected. He has an overall varus alignment, and this varus alignment is divided almost equally between the femur and the tibia. So we have two bones that are short and have an angular deformity. What can we do about him? The things that make me think about the algorithms that I use is that he is young, he's otherwise fit and healthy, and to restore his anatomy to as near as normal would be ideal. So I think both of the bones require deformity correction here. Here, the distal femur, to correct the varus in the distal femur, we can do internal fixation. He has had a closing lateral closing wedge osteotomy of his distal femur, which has been fixed with a plate. That's to get the lateral femoral angle, the joint line in the femur, correct. And then he has had an osteotomy with a lengthening nail, exactly like the ones that Tom was showing you in individuals who get leg length discrepancy. So this is a magnetic nail, and here he is post-operatively. You can see that his alignment has partially been corrected because we've only done half of the job here. And here he is, lengthened out. So his femurs now are matching. He's got a matching pair of femurs. And here he is, having united his femoral osteotomy around the nail and the distal femoral side that's healed now. We need to concentrate on his tibia. And the tibia, because there is both an angular and a length deformity, my preferred device of choice is actually a circular frame. And this circular frame allows us to perform an osteotomy in the proximal tibia. We gradually correct him. So this is the tibia corrected. And then we wait for the deformity, for the regenerate to consolidate. And here he is with correction of both axis and length. Rotational malalignments can also occur as a result of trauma. Here is a young man, he had a tibial fracture, and he's got patella anterior x-rays. You can see he has come in saying that he has got some difficulties with his hip, and he just doesn't feel that the leg is right since it was fixed because of the injury. So look, the alignment is good, but when you recognize that he's got a leg length discrepancy, you see that this has not been, there's probably a difficulty with the fixation of his tibial fracture. And it is a tibial leg length discrepancy that he's got. There is an indication of the rotational deformity because when you look at his ankles, here you look at the patellae in the knees are symmetrical, and when you look at his ankle, you've got a nice AP view of the ankle on the left side, and on the right side, this is an external rotation view. We've had this very eloquently described by Tom, looking at the thigh-foot angle and the variation of this angle as we age. We go from internal rotation to external rotation. The thing is, though, that this is not a particularly accurate way of thinking about rotational abnormalities, particularly when you are considering intervention. We can also look at the femoral anteversion, and again, this was described elegantly by Tom. For me, the assessment of rotational malalignment is best done with a rotational profile CT scan, where we take cuts at the level of the hip, knee, and the ankle, and we compare them. There are a variety of ways of measuring this angle. For example, in the tibia, you can use a posterior condylar line or a transcondylar line for the proximal end, and then a bimalleolar axis and a number of other ways to measure the distal segment as well. I tend to use the Weidlich, which is looking at the level of the ankle joint, and it is almost a transmalleolar line at the level of the ankle joint. The numbers that have been described for the mean torsion of the tibia, it does vary between various authors. So particularly in traumatic, post-traumatic individuals, what I tend to do is I need to compare it to the contralateral side. So here we can see that both the tibiae have been measured. We've got the posterior condylar line at the two images over the top, and the transmalleolar axis at the level of the ankle joint below. And we can see that on the right side, there is an extra 10 degrees of external rotation when we do these measurements. The treatment for this young man is to remove the hardware, perform a fibular osteotomy and a tibial osteotomy. My preference when we have a length and a rotational deformity is to use an external fixator, and here is the tibial osteotomy that you can see and the fibular osteotomy with the external fixator inside shoe. Here he is immediately postoperatively with the long leg alignment film on the left hand side, and on the right hand side you can see following correction. So I've corrected his rotation, I have regained his length, and then we allow him to consolidate his osteotomy, and after this the frame is removed, and you can see that we have got an AP of the knee at the top end and equally an AP of the ankle joint at the bottom end, so that his anatomy is now restored. Although you may think that the deformity he has is rather minor with 10 degrees of rotation and only about 2 centimeters of leg discrepancy, this is something that can be dealt with using either insoles, modification of footwear, and physiotherapy. There is a limit to how successful these are, and in particular in individuals that are young and very active, these deformities have a profound impact on their function. So the take-home message is really from today is that deformities can cause functional deficit. The way that we need to think about these is that it is individual, and different individuals, depending on the level of their activity and on their essentially their expectations of what their limbs should be, can present with different degrees of functional deficit. Really accurate assessment of these individuals is incredibly important, because we need to understand where the deformity is, how we're planning to correct it, and that allows us to counsel the patient about what to expect from a deformity correction procedure. And as you've seen, there are a myriad of techniques that we can use both in children and in adults to correct their deformities and restore their anatomy. So I'm just going to stop sharing there. So that's pretty much it from me. Thank you very much, everyone, for joining us. I don't think we've got any questions from the attendees. And I suppose if that's it, I'll round up from our webinar today. We've talked about deformities. Deformities are seen both in children and in adults. Sometimes the deformities from growth are relatively complex and require quite complex treatment to restore anatomy. The assessment is an incredibly important part, however. From the point of view of what we do with them, we're very happy to speak with you, advise you about your patients. If you have any cases that you want to discuss, we're very happy for you to send them to our secretaries, and we can do consultations with you as well as the patient to try and discern what the problem is. From the orthopedic specialist, our next webinar will be in about 4 weeks' time, and we have Professor Philip Schottel talking to us about patellofemoral problems. He's an absolute world authority on problems of the patellofemoral joint, and we're delighted to have him come and speak at our webinar. So that brings us to a close. Thank you very much for joining us.